Here we go. I think I can still salvage this game, Ron. I think I still got it, buddy. So you can get out of here. Come on. Does it even look like I'm really playing? Oh, I didn't, oh, sorry. Guess it's time to start this thing. And away we go there. That was an intense StarCraft game I had to get through right there, so. Thank you so much for coming to today's discussion around low back pain, and specifically what you can do with patients who attend with low back pain, or if you're a person who has low back pain, things you can do. And this is just something that we can do to give people a little bit of extra learning and opportunity to engage in content that we all know and love. So to start with, one of the key things that you have to be able to do is have a systematic approach for every patient interaction. Today, our interaction is going to revolve around the gamer that we just saw, your standard patient stuck over like this in their working position, which is what most of the world is right now. Most of the population is actually in urbanized environments, and we're seeing record levels of computer users and desk-bound people. So number one, part of the system that you want to develop is education, assessment, and then actions. Education is fundamental. Every patient interaction is an educational opportunity. You have a chance to make that difference in that person's life, and guess what? They'll make a difference in your life too. I learn as much from my patients, I learn as much from my students as they learn from me, and it's a fantastic back and forth, and I think it's one of the main reasons we all love to practice. The next thing is going to be your assessment, and you're going to hear me say this repetitively, but if you're watching this right now, you're going to get out a pen and a piece of paper, and you're going to write down, assessment is therapeutic. The vast majority of patients I wind up seeing, the assessment is as therapeutic as the treatments for the patient. Most of the time when someone comes in to see me, what do they want to know? They want to know what's going wrong and what can you do about it. So if we look at the next station right here, what can we do about it? Those are the actions. That's part of your system right there. Education, assessment, and then actions. Making that critical thinking come to life for the benefit of the patient and their overall wellness in the future. So, what I'm basically going to be doing here today is literally just going through this book on low back pain. I'm going to go through, it's actually a book that you're supposed to give out to patients. I'll show it to you really quick right here. It's not even more than 100 pages, but it has all kinds of useful information and mostly rehab exercises in the end of it. So all the simple stuff. And if you look at the exercises, they are nice and easy for patients to follow. But you are still established as the expert. One of the key things that you have to do is when you look at the back of this, you literally give this to your patient and you put your business card right here on the back of it. And it's a way for you to market your clinic and establish yourself as the expert for the patient's benefit and their long-term healthcare goals. All right, so with that out of the way, we're going to go ahead and continue on then. So the next thing we can see is the next slide. What are we doing? Yeah, I just want to put these out there for you guys. We have over 1,000 videos of palpation, muscle testing. All of that is available on our website, as well as a number of fantastic books that are required reading at universities and colleges around the world. Okay, so who is the expert in this case? The expert is the patient and you. This is one of my favorite expressions right here. If I is replaced with we, even illness becomes wellness. Even illness becomes wellness. We are working together to try and find a common goal. You are the expert. You have detailed training. Bring that detailed training and knowledge forward to the patient who has detailed training and knowledge around their own lifestyle and what they're actually able to do and accomplish as part of their daily routines. So if we look at what determines health, there are some key things that we can see here. Some of the key things that determine health include healthcare, which is where we come in as part of our treatments, about 10%. This is all evidence-based research. It's all in the book. You can look it up. Social and environmental factors, you can influence these. Individual behavior factors, our job as practitioners is to influence these behavioral factors. And even genetics. Guess what? Your lifestyle choices can influence your genetics. So really, we have ways to influence all of this for the total overall health of our patient, never mind just the low back issue that they might come in to see you with. It's all interconnected. If you're looking at neuropsychobiology, this is a major part of most of the treatments and where most of the research is actually going to show the best outcomes. Okay, so one of the key things that I need to cover for you guys is how to improve happiness. And this is one of the best things that I find myself doing in practice and in daily life. If you can just follow these 12 evidence-based steps right here, you will see better results for your patients, your own life, your own relationships, a fantastic way for you to go. So the first thing we can see is, number one, helping others. What are we all trying to do? We are all trying to help patients get better, help clients lead their best life, their optimal life. And you feel rewarded as part of doing that process. Practice smiling. It sounds silly. You guys are all watching this right now. What should you be doing? You should have a big smile on your face, be super happy, just glad to be here because it's such a fantastic thing. If you look at the research, even putting a pencil in your mouth so that you're like that is shown to improve mood and lower stress level hormones and other items like that. Next thing is plan a trip. Well, it's a little bit tough when you're in quarantine, but let's say you're not in quarantine. Planning a trip, plan it for the future, for the fall, maybe the spring next year, whatever it is. The visualization of that process is a wonderful daydream for you to look out into the future with. We just finished up the practicing smiling, limiting screen time. Everybody's got their little crack pad in front of them. They can't put it down, especially now. What you want to do is limit your time that you actually use that screen. So a lot of people are surprised when they try and get a hold of me. They're like, you didn't reply to my text in 5 minutes. No, I don't have my phone on me 24/7, all right? And I would suggest nobody should. One of the reasons we love our practice styles is that we get to unplug and be fully present with the patient. You should carry that forward into more parts of your life. Even for my kids, even for my family, even for the teaching, you just can't have that phone on in front of you. It just detracts the quality of real life, all right? And there's enough research that shows the more time you spend on devices, the worse your mental health actually gets. We are designed to be out and moving around, which will come later on in our happiness list right here. Next thing is practicing gratitude. So the big thing that I want to say is thank you all very much for being here and observing this video, and hopefully you'll have a lot of take-home tidbits that you are literally going to write down so you will remember them better. Practicing gratitude. I thank patients all the time for them coming in to see me, and I am always gracious and glad to help them help them meet their optimal performance and best outcomes. Next one is meditation. Meditation is huge. If you're bored every Tuesdays and Thursdays, you can come and do a yoga practice, which is a moving meditation, and then a shavasana at the end, which lets you unplug your brain for a little bit. Just disappear into your mind. Next one is going to be eating whole foods. Ain't no doubt about it. All right, when you're looking at this, the best diets are mostly for lowest risk of injury, lowest risk of disease, are mostly plant-based and result in eating whole foods, plant-based whole foods. Whenever you can have organic, the better off you're going to be. And the research across the board supports this. The next thing is going to be moving closer to work. I cannot stress this enough. You need to live close to where you work. Do not waste your life in a commute. It degrades the quality of your life. It makes you feel fatigued and tired and irritated. Live close to where you work. And if you can, walk to work. If you look in the book, we talk about walking as one of the key rehab exercises you can give anybody with low back pain or any type of pain. And a walk of 10 to 15 minutes winds up being one of the best exercises that you can do. The healthiest people in the world don't go to the gym. What do? They incorporate exercise and activity as part of their daily routine. Walking is what we are designed to do. Next one is going to be spend time with friends and family. That goes without saying. Anytime you can have positive interactions with people you love and care about, it's always going to improve your mood and quality of life. Next one is going to be go outside. And I cannot stress this one enough. Get outside. So right now we're in quarantine with our kids. We have a wonderful schedule set up by my wife. What do? You have an hour and a half of work time, and then at 10:30 it's snack time, and then you're outside for an hour to an hour and a half. Beyond that, you'll then be outside, you'll come back in for lunch, then there'll be another bit of work time, and then you're outside again. Spending time outside improves outcomes for people. Next one is going to be better sleep. If you have good exercise and diet and limit your screen time, good sleep follows. Sleep is where your body does recovery. And I cannot stress that one enough. Sleep is where the body does recovery. Moving on from there, we can go ahead and see exercise. And this is the biggest thing. If you look at our book here on low back pain, a full 1/3 of the book is just dedicated to simple exercises anybody can do, progressing from least invasive to more invasive to help motivate people to get them moving. Movement is one of the best therapies you can give any patient. All right. Sleep counts. What do you need to do? There's a couple of good things you have to do for excellent sleep hygiene. Number one, have a set schedule. Get up at roughly the same time every day. Number two, 15 minutes of sunlight in the morning, whether it's real sunlight or you have artificial lights that are full spectrum bulbs, it helps improve your sleep later on in the day. Relaxing activities before bed. And what does that mean? That means no screen time. How many people go to sleep looking at their phone and their phone is in reach? You cannot do that. There should not be a TV, there should not be a screen anywhere in the place that you sleep. That is a dedicated place for your body to recover, lay down new memories from the day, and make yourself better at what you do. Okay? And the last one is, use your bedroom only for sleep and for sex. We'll get to that one a little bit later when we have some rehab exercises for you on those topics. Okay, moving on. Working with pain. What do we have to know? This is the key system that I use with every patient. Pain is not necessarily a bad thing, and you have to help patients realize that and how they can work through the pain that they're dealing with. So one of the key things for us to get is focus on goals. Number one, focus on their goals. Number two, bring awareness to the area. Just make sure they're aware of the area that's injured. Just ask them to think, and their brain will put more neurons focused on that region. Okay? Number three, differentiate pain from sensation. Now, usually what happens when you hurt yourself is you have a little bit of pain to start with. But you go ahead and that pain starts to decrease, but your body still remembers the significant pain, so you're scared to challenge that new range. Is it really pain, or is it a fear of future pain? There's a huge difference right there, and huge outcomes can be realized if you know the difference between those two things. Next one is going to be identify contributing factors. So, contributing factors are going to be anything in their activities of daily living, even their mental psyche setup. All of that's going to be involved in what could limit their ability to fully recover. Last one, discover positions that reduce pain. Your active range of motion. Everybody put your hand up. You're going to be doing active range of motion. And the next one is going to be challenge movements that cause pain. So you have pain, move into them a little bit, come on out. A couple hours later, move in again, come on out of that range. Keep on challenging it. As long as you challenge the range, you're going to see better outcomes with it. If you don't challenge the tissue, it's going to have a much harder time healing. So you want to challenge the tissue. If we progress forward, this one is fundamental for you to get with patients. You have to realize this fear avoidance model. What happens? We have an injury. There's damage to the body. You have pain, and now we have a choice with this pain. You can catastrophize, or you can go into low fear. Now, let's be honest. Who out there catastrophizes? Put your hand up. I catastrophize. Everybody does. But our goal is to put it into a rational area. If you catastrophize too much, you wind up going into this area of fear of re-injury and pain, avoidance and hypervigilance, and you continue on to disuse and depression, and it becomes a cycle. Let's just stop right there. How many of us have patients who define themselves by their condition? Oh, I have low back pain, so I can't do that. Oh, I have scoliosis, so I can't do that. Oh, I have a rotator cuff tear, I can't do that action. These are very limiting things, and it's a thought process that really does most of the limiting for that patient. If we continue on, what is our job? Our job is to switch them from catastrophization to low fear. We create a safe environment with a knowledge base to push them into this range of low fear, not no fear, low fear, where they return to activity and see recovery. And across the board, it doesn't matter what the condition is, the sooner you get back moving, the better off you're going to be. So you can hear it in the patient's voice when they're talking to you. This is a patient saying, if I get better. This over here is a patient who can visualize future wellness, and they are saying, when I get better. That is our key focus right here. All right, the next thing is, there's a lot of tissues in the low back, a lot of things that can go wrong if we're going to be specific with it. If you're sitting down like this for a prolonged period in the day, oh, it just hurts me to look at it, but then I'm looking up and working on my computer. What am I looking at? I'm looking at a fairly significant injury right here, all right? And you might say, what do you mean, Dr. Nick, a significant injury? The significance is, it's not a rapid strain, it's a slow deconditioning of the body. The muscles are not engaged or used like they would be even if you were just walking, and you're having a slow strain. If you take something and you pull on it and you keep on pulling on it, the tissue gets a little bit longer, a little bit longer, a little bit longer, and you can induce, through hysteresis and creep, or the technical terms, slow strains in the body. And then we have to go ahead and figure out what tissue is damaged and what's going to be our best healing opportunity. So first thing that we can see is, number one, we can see muscle injuries, ligament, bone, joint, nerve, viscera. All of these different tissues can be injured and can refer into the low back. and it's our job to figure out which of these tissues, or potentially all of them, are involved and what are going to be the best treatment options. This is a graph right here as well that shows us just tissue adaptability. By far, the fastest adapting tissue in your body is the nervous system, and then beyond that, it has to do with blood supply. The better the blood supply, the better it adapts. If you go onto YouTube and type in Vizniak tendon growth, we got a nice video there that shows the size of some tendons on different people, so you can see how tendons adapt to load over time. All right, assessment is therapeutic. People want to know what is going on with them and what you're going to do to fix it for them. This term, non-specific low back pain, I find myself very frustrated with that because we can usually find or attribute at least a few causative agents in the vast majority of cases. Non-specific low back pain tells me that maybe we need to look a little bit deeper at what's going on with that patient. And the purpose of this class is to take you through some of that content. So let's look at some of the anatomy of the low back. We start off with bones, building our framework, and then step out into ligaments. Ligaments step out into muscles. Muscles step out into skin and superficial tissue. And interwoven through all of this are going to be the blood vessels and nerves back and forth through it. A couple of key things that I want to point out for overall anatomy here. Number one, the vertebral bodies are designed to carry the weight, but the intervertebral disc itself is actually ligamentous on the outer parts. So most people with low back pain, we're talking about that crunching over sitting position right here, what happens is they start to have sprains of their discs. They have small micro tears of the disc that result in the effective same injury as a sprain of your ankle or whatever else it is. Little tearing that occurs with this. This is in Kirkcaldy and Willis's pathway of degeneration of the spine. We'll show that here in a little bit once we get into a little more detail. All right, beyond that, if you have a degenerated disc, so you've lost your nucleus pulposus, what does that mean? The biomechanics of your spine now change. This disc that should be a shock absorber, carrying about 95% of the weight up here at the front, has lost a lot of its shock absorption ability, and now you carry weight for the same position of your back more into the facets. So we see our facet spondylosis occurring back there. Degeneration of those facets occurs with it. It is important to load lightly and unload your facets, to load lightly and unload your spine. Flexibility with strength in your spine is fundamental for good outcomes and long-term spinal health. Yes, and of course we talk all about this in the low back pain book. Okay, here's what it looks like on a real cadaver dissection. This one took forever to do, but what do we have? We can go down here and look at these vertebrae and say, some of these vertebrae are not like the other ones, not what happened to that at one and what happened to that at one. So we've got two vertebrae here that actually have compression fractures. Now this person was only 58 years old, they died of cancer, and one of these is an old compression fracture and one of these is a recent compression fracture. But what do they have? They have a fantastic, an absolutely fantastic intervertebral discs. Nice and thick all the way through here. Those are beautiful discs designed for good shock absorption. A couple of other things for orientation right here. We can see the spinal cord right down here. These are spinous processes out the back. And this little ditty, which is about that thick right there, is actually the iliopsoas running through right there. So iliopsoas in the front. If we look at another picture, we can see the erector spinae. These are my hands. See if I can get it right in the camera there. These are my hands right there showing you the thickness of the erector spinae on your back. These are big, thick, strong, powerful muscles. This cut is parasagittal, just slightly lateral from these transverse processes in the lumbar spine. Big, strong muscles all the way through there. What have we been working on? One of these little ditties right here. It is a fantastic model. This is a moving spine model that shows, and let me just tighten up my erectors right here, that shows the rotatories, the semispinalis, the multifidi, this iliocostalis, longissimus, and spinalis are going to be shown here. And then we go over top and we're going to show the superficial muscles of the back. And all of this can be shown real time so you can see how the spine actually moves back and forth. Super cool. Is that super cool? So we can go ahead and see for this location moving in slow motion how each of the muscle actually moves back and forth and from side to side. We can see that we've used different fiber and elastic widths to demonstrate the size of the muscle mass. Again, this is a working model, so we will eventually be adding the superficial layers, but it's really neat just to see the stability that's there from the multifidi, rotatories, semispinalis, all the layers as you progress through the low back.
in addition to having the ligaments and other structures. Super cool.
I think that's super cool. So when this model is done, it is going to be fantastic. Got to stand my skeleton up here before I lose this guy. All right, so there you can see the real anatomy that's involved. I love to show this to people in cadaver labs. One of the key things for you guys to understand is what real anatomy looks like. You just cannot get it from a textbook. And in fact, I would suggest to you unfixed donors are really where it's at. Somebody who just recently passed away, having them on the table is one of the best learning opportunities that you will ever have, and it is way different than fixed specimens.
So here we are in the laboratory again with an unfixed donor. How do you know it's unfixed? Because you can go ahead and see how viscous and fluid the tissue looks and also how malleable it is. So for orientation, this is a low back dissection. You can go ahead and see the iliac crest on the lower left-hand portion of the screen right here that we're outlining. And if you look over above, it's along the spinous processes in the midline and looking up to the lower part of trapezius and latissimus dorsi as well. If we take back this section, you can actually see how thick adipose and superficial fascia is over top of the muscle layers. And again, we leave these skin windows on purpose so people can come back and look at the thickness of those layers. If you peel it back, you can also see how thick that tissue is. If we look at it from a side view, you can definitely locate the thickness of the adipose, and then inferiorly you can see the erector spinae muscles. Again, we're looking at a ratio of approximately 3:1 muscle to adipose. Now, the body mass index for this person was around 30, so a little bit on the higher side, but not morbidly obese by any means, just slightly overweight. So we're looking at some key things here where we can see a lower part of a rib attaching. We're actually looking into the viscera below where quadratus lumborum would have been. Moving on, we are now going to progress into a intervertebral disc. This is a transverse section through the lower thoracic spine. And a couple of key things to note here, again, unfixed, is you can see the abdominal aorta, or thoracic aorta in this case, coming down, the annulus fibrosus, just how thick that tissue is, and the gelatinous nature of the nucleus pulposus of the disc. Again, the annulus fibrosus is ligamentous in nature, very avascular. Moving more posteriorly, we can go ahead and see the meninges and the spinal cord. Again, unfixed donor, so you can see the spongy bone and spinous process running up. And more over to the lateral side, we can see the head of a rib articulating with the vertebral body and annulus fibrosus a little bit. And out to the lateral side, we can see the muscle mass of the erector spinae. Now, this donor was actually quite lean and had very low fat content. As we progress to a posterior view, we can go ahead and see, again, with the skin removed, we're just going to demonstrate some myofascial stroking techniques through the back of the muscle here. One of the key things to appreciate is how much you actually affect the tissues around when you push, especially on this lower lateral view. We're going to sink in here and push through, and you can see that it pulls fascia and how viscous the fluid is, the tissue is, again, in an unfixed donor. So one of the key things is you can definitely get a different texture sense when you're looking at these regions and palpating with unfixed. I cannot stress it enough what a difference it makes working on unfixed tissue. Here we're using a reinforced contact, then we'll progress over into the spinal laminar groove with a reinforced thumb contact on the opposite side. Next up, we are on to a fixed donor specimen, and here you can see the erector spinae. This cut is slightly parasagittal, and the erector spinae are quite thick. Anterior to that is the iliopsoas that we're outlining right now, and the lower part is going to be, this is the sacrum here, and you can just make that out. Again, you can see the difference in tissue when you're looking at fixed specimens, how less malleable, how less movement you're going to see with that. Also, even just look at the color, right? The color is different because of the embalming agents that are used. But one of the key reasons that I like this type of a dissection is it's easy to show you the actual thickness and how the iliopsoas and erector spinae wind up sliding back and forth on each other on that part of your lower back when we're having to deal with these low back pain type cases. Just a neat way for us to see it. Moving on to a little bit more, we can go ahead and talk about giving a massage or doing a joint mobilization. When you push through the tissue, you're going to see this in here just a second, how it actually deforms the tissue. And think back to that unfixed specimen, how much more malleable it was, but even in this fixed tissue, you can see how much fluid is being squeezed out of it. And the other thing to appreciate is I'm 6 feet tall, these are my hands right here, and you can see how physically thick the erector spinae are and how you're moving through those and causing stimulation of tissue neurologically and movement of fluid through that tissue by challenging it with manual therapy techniques such as massage therapy and joint mobilizations. It's a little bit different when you switch over to instrument assisted. For the same amount of force, observe how much fluid moves now, right? Your stimulation is going to be more specific. Every stroke is going to count for a little bit more with this when you go instrument assisted, but still having relatively the same effects as general hands-on manual therapy. Super cool to see, really interesting for everybody to observe. Most people do not get to see that in the lab, so yeah, really good to see. The last thing we want to show is moving back to an unfixed donor. Here we can see a contusion in the skin with bleeding below. This is what bruised, damaged tissue actually looks like when you first have an injury. Most people have never seen this before. Again, unfixed donor, we are looking just through the skin into the superficial adipose layers. And bruised tissue is blood outside of blood vessels in interstitial space, and you can see how it's deformed and filled up, and you get this color aberration that you see superficially on the skin. Really interesting for people to see and go ahead and palpate. We know this is a relatively recent injury because it has not formed any type of proliferation or scar tissue.
Okay, so we've talked a little bit about the system so far. Now we're going to go ahead and review some of the process of the low back biomechanics and kinesiology so we understand that. This graph, I show this graph all the time to patients. It is nice and simple and easy to follow. A couple of key things you have to get. Number one, this is the overall pressure on your back, specifically on the disc, and this is the motion that's occurring to increase that pressure. In general, if you want to wreck your back, the way to do it is a lifting, twisting event like this. And if you go ahead and type in Vizniak disc herniation on YouTube, I've got a little 10-minute video of where I herniated my own disc back in April of 2019. And what was I doing? Like an idiot, I had already spent the day lifting and moving a bunch of heavy steel around, and then I'm sitting here like this, trying to toss around pieces of granite that are heavy, and I'm twisting and moving, and you can go and look it up. Perfect way to hurt your back. Lifting, twisting event in a flex position, okay? But for patient education, we want to talk about the importance of appropriate lifting and all this good stuff. We have to recognize standing is the neutral position, 100% load. As you progress through, you can see that even sitting, the more you flex, the more pressure it puts onto your lumbar spine. So back onto this person sitting in their desk like this. Oh, how can I even get into this? Even this person sitting in their desk like this, working away, doing whatever they're doing, this is going to make things worse for them because it stretches out the back of that disc, can cause some of those micro tears with prolonged positions, okay? Moving around, changing position is where the win is actually going to be. If we look at when you lift, if I lift 20 kilos, so that's 40 pounds, not that much weight, you lift that up, that's a 300% increase in load onto that low back disc. If you lift with bad form, this is you rounding out your back, you're upwards in the 485% range. These are huge potentials for injury that occur right here, 485%, and it gets bigger than that. That's 20 kilos. If you want to go look at a great story, Mr. Olympia, Ron Coleman, he's got videos of him deadlifting in excess. What would he do? A squat for 800 pounds for 2 reps. And it was a full squat. They've got videos of him deadlifting crazy weights. And you look at him now, his body is basically shredded up and falling apart in his mid to early 50s. All right? And it's repetitive load. Yeah, your body can get up there and you're going to be king of the world for a while, but repetitive load over time, additive effects take their toll on this tissue. Now I know because I've had a disc herniation, my chances of having future low back issues are higher. I've dislocated this shoulder. Chances of shoulder future issues are substantially higher on this side. All right? All right, we'll talk more about the shoulder one when we do our advanced clinical reasoning later on. All right, so this is a great graph for you to show people. Laying down, when you're getting that good quality sleep, your discs are actually rehydrating. They're pulling fluid back in. And the fluid movement in and out is moving nutrients back and forth. It's how the tissue is designed to heal. You have to move it, okay? Another great way to move it is some light spinal flexion and extension, and we'll show that with some of our yoga movements later on. Okay, next up, what do I see? I got to do my clicker here, 2 seconds. Good chunk, there we go. Next up, you have to be aware of this fact, and it's a delicate conversation to bring up with some patients, but it is a matter of fact, and most people are aware of this. Your body mass counts. The heavier you are, the more weight your low back has to take, and the greater the strain can potentially be on it. Now, what are we all? We're all a bunch of sugar addicts, so what are we doing? We're always looking for that bag of sugar. If you carry a 9-pound bag of sugar out in front of, sorry, 9-kilo bag of sugar out in front of you like this, that's the equivalent of giving you about 400 pounds, 180 kilos of weight over your lumbar spine. So if you are just 20 pounds overweight, you're looking at increasing the pressure, 30 pounds, 40 pounds, 50 pounds. With 75% of the US population overweight or obese, you're looking at a huge run on low back pain cases and injuries, and we can influence that by some very simple changes in diet and lifestyle. Simple things can make a big difference for people. All right. Next one, lumbo-pelvic rhythm. So if somebody does have an injury, the first place that I always like to start with my assessment is going to be simple range of motion. So you're going to have your person standing up, they're going to go ahead and flex forward, and watch how they flex. If they flex forward and you see them go, oh, and they're like, they've got the pain and they don't want to go, or the legs catch like this, you're looking at a significant change in their overall ability. A lot of people will go ahead and stop their patient right there and say, no, I don't want you to go any further than that. What I'll usually do in a safe way is I'll ask them, can you go a little bit further, or is that the limit? And if they're going to have to stop, they'll stop. But almost to a person, unless it's a really significant injury, they're going to come in and lean forward and say, oh, it feels worse, worse, worse. Oh, you know what? It feels a little bit better when I'm all the way down here. And then they'll have to get themselves back up and through it. Already, that was a therapeutic interaction right there. Their nervous system has changed how it's looking at that tissue injury. So you want to get them moving and challenge them a little bit into it. Now, the case of the lumbar disc herniation that you can look up on YouTube with that Vizniak YouTube video, Vizniak disc herniation one, she gives her story right there. The first time she came in, she could absolutely positively not bend all the way forward like that. But the second time she came in, she was halfway down. The third time she came in, she'd get 3/4 of the way down. Fourth visit, almost all the way down. These are outcomes that matter, because the real outcome for this patient that mattered was she could pick up her baby that she couldn't pick up before. This is where the real differences in your physical medicine opportunities really lie, is making those kind of changes for people. And it all starts with showing them that they can do things they don't believe that they can do. Our basic assessment right here, lumbo-pelvic rhythm. All right. And again, these are all just in the book. I'm just talking through all of this stuff. Okay, so one of my key things that I'll always do to start with for low back pain is, let's do all of your ranges and see which directions feel better. So they're going to move from side to side, spinning actions, whatever works. The actions that feel better, you're going to move more into those, and then lightly challenge back the opposite way that doesn't feel as good, to the patient's tolerance. What do we call it? So it's easy for patients to remember? Joyful discomfort is what you're looking for, all right? Joyful discomfort. All right, and you're looking for, especially if they have radicular symptoms or numbness and tingling down the leg, you are looking for centralization of those symptoms. If their numbness and tingling is all the way down to their toes and they move a certain way and it goes to the back of their knee and doesn't go down to their toes anymore, that is a direction that you want to move. As simple as that. All right. Yes, differential diagnosis. So now you have to go through and figure out what are the actual causes of pathology. So you can look at this list and cycle all the way down at anything from abdominal aortic aneurysms to pelvic fractures, you name it, and I give you a quick summary in 3 lines or less. Now, this is just meant to be a quick place for us to go to look for information when you're trying to figure out what's actually going on with this patient. Realistically, we break each one of these conditions down. So I'm going to break down the top 3 things that cause low back pain. So number 1 is going to be a sprain strain. They have actually torn some of the muscles and ligaments in their low back. There's a nerve sensitization in that area, and now they've got low back pain that occurs with it. Well, how do you know you've got a low back strain? Did you hear any snapping or popping at the time of injury? People often hear it actually snap and break loose. I've got another story that you can look at, and it's on that disc herniation one. If you type in Vizniak disc herniation, it's the one where I'm talking. I talk about how I actually tore a ligament in my back, and it was fairly obvious to me because I felt it actually snap and release. All right, you can do your active and passive range of motion assessments. You can palpate. You can push on tissues to selectively push ligaments or selectively push muscles. What else? Rehab exercises for each one of these are given at the end of each section. So again, just referring back to it, all of it is right here in this low back pain book, so we've got all of that. But you want to keep it simple for a patient, and you still want to establish your expertise. So who is the expert? You are the expert. all right? So a couple of key things that you're doing here is you're going to give the patient some rehab exercises to do, but they need to do them in front of you to make sure that they're doing it safely and they're getting their optimal benefit. That is where your expertise comes in. Yeah, and then we talk about lifting technique too, but I'll get into that here in just a little bit. Next thing is going to be lumbar DJD, and this is a process that is extremely common that we're going to work through here. So lumbar DJD, how do you recognize it when somebody comes into your office? The first thing you're going to look for is morning stiffness. That's better with a little bit of activity, worse with excessive activity. What else are we going to see with that? It may get worse with changes in the weather. They probably have a history of prior injury. The real diagnosis, though, for osteoarthritis of anywhere is going to be an X-ray. And there are 3 key findings you are looking for on the X-ray. A non-uniform joint space loss. When you lose joint space, what does it mean? It means you have lost cartilage thickness. And that's the same in any joint in the body. You have lost cartilage thickness, cartilage is getting thinner, that's one of the first processes. The second thing is reactive sclerosis. So what does the bone start to do? The bone starts to remodel, and osteoblasts lay down more calcium and hydroxyproline and all those good things to increase the density in that area that's getting an abnormal load onto it. And the last thing you're going to get is osteophyte formation. The body is working so hard to try and stabilize that area. What does it wind up doing? It winds up spreading out and giving more surface area for it. And in severe cases, and we're talking extremely severe cases, you'll actually go all the way to ankylosis, where it'll fuse together because the body doesn't want to move that anymore. Conditions like diffuse idiopathic skeletal hyperexostosis is one of them. DISH. We see that fairly regularly on our cadaver dissections of extremely old geriatric patients. What are your treatment options here? I would suggest you start off nice and light with some very simple Tai Chi, light yoga classes, just simple, graceful movements that start to challenge the tissue a little bit. That's all you're looking for here. Next one is going to be lumbar instability. Is it possible that you can have vertebrae that slide around a little bit because they're unstable? 100%. It's called spondylolisthesis or retrolisthesis or anterolisthesis, whatever you want to say. The core stabilizers get a little bit loose here. So key things for this in the history is prior injury to the low back. Probably what happens is they move and they get a little click or a catch every time they move. They might even move like this. They'll move down, shift to the side, and then come back up when they're moving back up in the other direction. And the reason that they're going to do this is because they have a section of instability. It's easy for us to see instability in the shoulder because the person moves and it goes click, click, and then it comes back down, all right? That click, click is easy to see because the glenohumeral joint is highly mobile and fairly superficial. The same thing can happen in the low back. The simplest test that you can use for instability that I like to use, patient laying prone, totally relaxed. I'm going to go ahead and just push P to A on their spinous processes. That takes the entire vertebrae. Did you say vertebrae? We got one right here. That takes the entire vertebrae and just shifts it back and forth. Well, if you have damage to this ligament right here, and I shift you back and forth, what winds up happening? It usually goes ow, 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 versus if you have them contract their muscles, and now you do that same test and they're stabilized and the pain goes away, very pathognomonic for that condition, all right? Okay, instability is an example where maybe stretching routines are not going to be your friends. If you have instability, I have a number of patient cases that were referred to me where, well, one example that I'll think of right here is a steel worker who's building high rises. He has to pick up big pieces of rebar and move them around. So what happens? Goes and sees a super therapist. They relax all of his muscles out. The next day, he's feeling great, nice and loose. Goes to pick something up the same way as before, but because he's so loose, he doesn't have the same stability and strength to keep his back strong, and he actually winds up causing more damage and is out for 6 weeks on a workman's compensation claim. If you have instability, you have to be very careful about loosening up that tissue. All right, so that's instability. You're looking at exercises that involve increasing stability, and you're always going to work at the level the patient can handle. Next one is going to be lumbar disc herniations. It boggles my mind how many people cannot pick these up because they are so obvious, all right? Lumbar disc herniations. History of bending, twisting event, prior back injury, pain is worse, and you have to ask this question for every low back case. Please, just stop what you're doing. Just shake your head a little bit. Every low back case, you have to ask, Is the pain worse with coughing, sneezing, or straining? This helps rule in or rule out the presence of a lumbar disc herniation through a Valsalva maneuver. Those are all Valsalvas. If your low back hurts when you go like this, that is highly indicative of a lumbar disc herniation. Sorry, I get a little bit emotional around that one right there too. My voice kind of cracks up a little bit. All right, what else should you see with this? The other thing that you're going to see, if you cough and you have shooting pain that goes down the back of the leg, past the knee, into the foot especially, again, highly pathognomonic of a lumbar disc herniation. Did you know that you are better than an MRI unit at distinguishing where lumbar disc herniations are? 100%. If you know the DTR, the detent reflex, the motor, and the dermatomal changes, and the muscle weakness that occurs there, you can calculate where the problem is better than a picture of an MRI. And we're going to talk about the issues with MRIs and X-rays here in just a little bit. Other tests you should be doing for this one, absolutely positively, please just do a straight leg raise. Assessment is therapeutic. Guess what? First time somebody comes in, they get numbness and tingling right here, you bring them back down. Second time they come in, second visit, you lift them up a little bit higher, record the ranges of how far they're able to go up, and look at those as outcomes to tell the patient they are doing well, things are getting better. All right, a huge one for you right there. So straight leg raise test, an excellent test. You can go into our orthopedic assessment book and look at it in detail. I think we have over 15 references on straight leg raise tests. So you can trust this test has good statistical reliability, validity, sensitivity, specificity, positive and negative likelihood ratios. It's good, okay? Just get it, it's good. All right, then we're going to go into treatment options here. We talked about centralization. Best treatment options have been around for decades and they are proven to work. McKenzie extension exercises, William flexion exercises. It depends what kind of bias the person has. You've done your range of motion to go through to start. Some people are going to feel better with extension. Some people are going to feel better with flexion. So you flex them forward and they're going to say, oh yeah, that feels better. Then you're going to work on the flexion exercises. If you have really acute, significant pain though, where you generally want to start is going to be with just some simple pelvic tilts. Back and forth, side to side. Get them to do their little hula dancing, whatever it's going to be. Okay, something like that is going to make a difference. I wouldn't do the hula dancing unless you're trying to have fun with them. Okay, the other thing that I have found as a real winner, and again, I would strongly encourage you just to go to YouTube and Vizniak disc video. If you just do cat-cows, you are moving in an unloaded spinal position. One patient there for the breastfeeding one example that I gave, she could only sleep in this position. You know the pain is bad when you have to sleep, well, when you're on morphine as well, but when you have to sleep in child's pose, all right? These unloaded spinal positions are a safe, light way for you to load your spine. And it is insane how many people are so body unaware they can't even do this. And we'll come back to this in a little bit, all right? Okay, next thing is, let's talk about diagnostic imaging. Do I need a scan? This is one of my biggest pet peeves in practice. Number one, a lot of doctors and therapists are lazy. I can't do anything until I see a scan. We know the research is out. It conclusively shows that unless the scan is going to change your treatment, it offers no benefit. In fact, the scans might actually be making it worse because now you get a bunch of findings that the patient might fixate on that are not even the real causes of pathology. If we did an MRI of the general population and we sampled through all age groups in the bell curve, we would see that anywhere from 50 to 80% of people have some form of disc degeneration or disc herniations, and it increases as you get older. It doesn't mean that's where the pathology is coming from. Now here's a great study that we're putting in this book right here. So what was this study? This study was a patient, the same patient went to 10 different, can't do it, there it is, 10 different MRI suites. And what did they do? They got scans done of their low back. Between those 10 MRI suites, no radiology reports were the same. No findings were consistent all the way through. There was a 45% miss rate on the MRIs. Let's understand what an MRI actually is. It's an image of the body, of the real anatomy internally, with no clinical correlation. Number one, huge finding right there, no clinical correlation. Number two, by a radiologist who is basically cycling through image after image after image. Number three, of someone describing a picture. So we get the significance of that. If I showed you my hand, and I asked you to describe my hand for me, you would write it out a certain way, the person down the street would write it out a certain way, and I would write it a certain way, and all of us would have slightly varied descriptions of this hand. That's all radiology reports are. They are descriptions of pictures. I always want to see the imaging myself and then talk about it with the patient. Realistically, they are of relatively low significance in the vast majority of cases. Imaging has a lot of false positives. Why you see a lot of surgeries done where there's a negative outcome on the surgery or there's no change is because when they go in, they do a discectomy and remove part of the disc, it may or may not have actually been the pain generator for that patient. All right? So we want to know that abnormalities found on scans are often asymptomatic, and the body of evidence and research on this is just growing and growing and growing. So scans do not make people feel better. In fact, they might actually make them feel worse. Your job, as part of your assessment, is going to be saying, nope, this is not an issue. I've had people come in who have relatively normal looking spines on X-ray and MRI, and they can't even barely move. I've had other people where it looks like the one vertebrae is collapsed into the other. This guy was the former powerlifting champion of Ontario, out in Vancouver, saw him. And his one vertebrae was jammed into the vertebrae below, and he was still moving around. He's like, yeah, it's sore a little bit, but he was still moving around. The best thing you can do is encourage your patients to try and maintain their normal activities of daily living. All right, next one. Now we're into treatment. So this is a key thing. Might want to write some of this down, some good information right here. Focus on goals. This is where your application has to be centered. Always focusing on goals. What does the patient want out of this? How can you help them facilitate that ultimate outcome? Evaluate asymmetries and balances. These have relative variations in their importance, but for some people it is a good way to fixate on making sure they have good lifting technique and good activities of daily living to avoid future injury. Next one is going to be increasing circulation. We know this, okay? The more blood flow you get, the better the tissue heals. It's a simple across the board factor right there. I would also say increase neurogenic ability into that area as well, so overall understanding and proprioception and biofeedback from it. Increasing strength and flexibility. Increasing strength is one of the biggest ways you can prevent future injury. It's not only strength, it's also firing patterns. So getting people used to moving in different directions so they're ready to take forces that they're not so equipped to do if they just do linear type motions all the time. Linear type motions all the time. Next one is going to be symmetry and balance. So in younger people, you're going to definitely want to work on just the overall symmetry and how they can maintain movements with their left and right foot or whatever else it is, upper body. Here's one that you can try at home. Let's all brush our teeth. Brush your teeth with your dominant hand. You're going to be cycling through like nothing, covering every surface. Your left hand, you'll probably hit yourself in the nostril, catch yourself in the ear, and then slowly work your way through. But you're trying to find balance through the body to work on both sides. Okay? Balance is always a win. Symmetry is what I mean. Symmetry and balance. The other one is as patients get older, you're looking at fall risks. So if you can work on standing on one foot, you can actually predict somebody's age based on their ability to stand on one foot and how long they're able to do that. And we talk about that a little bit in the book as well, so we can come back to that. And then you want to reduce, modify, or eliminate dysfunctional patterns. And this can be movement patterns, but this can also be patterns in their lifestyle, relationships, whatever else it is that can be part of the overall picture for this patient. Okay, for this patient. So that's a good quick summary of your treatment options that you're looking at. For those of you who have done lectures with me before, I think this is one of the best graphs that we actually have, okay? One of the best graphs we've ever done. So a couple things right here. Number one, on the top, it's showing you different tissue injuries and how they heal. This is a muscle injury. This is a ligament injury. This is a bone injury. So we can see how they progress from injury, inflammation, to proliferation, and then remodeling eventually. We can influence these stages. This graph down below here shows you the differences in those stages, and the black line is the key thing, the tensile strength of the tissue. The biggest thing that you have to get from this image is you have to load tissue to heal tissue. Say it with me with a smile. You have to load tissue to heal tissue. If you don't load it, the way that the fibers are laid down and the quality of the tissue is much lower quality. You want to create the strongest bonds, the strongest tissue you can with flexibility to get appropriate function overall. So if we're looking at this, we can see that tensile strength increases within 5 days. You're already working your way up there. You should be challenging that tissue within 5 days. And as a prime example of this, let's go ahead and look at a hip joint replacement. So we understand this injury. This injury is literally a slice through the side of your thigh. It gets opened up. the top of your femur gets cut off, dislocated from the acetabulum, a metal rod is jammed down the femur, and then you're putting a plastic polymer inside the acetabulum, stitching it all back together. This is significant body trauma, yet we know the best outcomes happen with early movement. When are you moving? Yeah, you're moving within 24 hours. They're up, they're kicking and moving back and forth. They're starting to lay down this collagen, stimulate the nerves in the area to develop more normalized tissue, optimal tissue after a very significant trauma. So that's all this graph is trying to show right here. All right, the next thing is, what are we going to do about it? There are lots of options right here. We are going to work with the patient to establish our clinical expertise. But the biggest thing I have to stress, if you have a pen and a piece of paper, write this down right now. This is one of my key concepts for this lecture, is going to be progressing from least invasive, we have to make sure good nutrition and all that's already done, nutrition, social support, activity level, but you're going to go through talk therapy, simple meditations, soft tissue work, all the way up to surgeries. You are going from least invasive to most invasive. What is the least that I have to do? The word is minimal effective dose. Say it with me with a smile. Minimal effective dose. What is the least that I have to do? All right. And then we're going to progress into the basic treatment protocols. You can look at all of this kind of stuff. Jason, if you're watching right now, you can actually see our discussion about heat and cold right down here with some research articles. What's going to work better for you? I talk about acute phase, post-acute, remodeling, functional stages, return to sport, all that's here as a rough outline in the book. But here you can go ahead and see treatment frequency. And this is something that we do see a little bit in the literature. It looks like if you treat a patient a little bit more often early on in their condition, that helps with them, but with better motivating factors to get through it. And you tend to see better outcomes than if you're spreading your visits out over the same number of visits, but over a longer period of time. One of my goals in practice is always to eventually not see a patient again so that they're fully better, or they'll need to come back for a maintenance or kind of tune-up visit. And what you want to do here is see them more often at the start and then cycle them off. The more active they are to a point, the less often you actually have to see them. So kind of a key point right there for us to get. All right, next thing is, yes, protecting your back. People always want to know about protecting your back. You want the simplest way to protect your back. The easiest way to do it is to keep your nose between your toes. What does that mean? That means when I go to move, as long as my nose, like there's a big snot drip hanging down right here, is between my toes, it means that we can go ahead and be in a relatively safe position. Out here, am I still safe? Yep. Out here, am I safe? Probably not, especially if I reach and twist and try and grab something heavy. Okay? Same thing. Get out to the side. Am I going to be safe? No. If I squat down, nose between my toes, I'm still going to be safe. All right? Now, you have to explain that to patients because people will hear you say that and then they'll wind up doing this. Keep your nose between your what? And they'll put their nose between their toes like this and they'll wonder, is that? I don't get it. Okay? It's like there's a laser beam dropping down from their nose and it's between their toes when they're moving back and forth. Nose between your toes. Easy for patients to follow. Now, if you have to lift heavier, there are other things that you can do. Abdominal bracing works. If you want to teach abdominal bracing, it is not bring your belly button all the way into your spine. Okay, what is it? It's actually creating a cylinder of support all the way around. And weightlifters will do this automatically because they'll put on a weightlifting belt that'll hold that nice cylinder of support. We talk about the process to go through that right here. Next one is going to be 8 commandments of lifting. Again, in the book, just a simple thing. You can have your patient actually take a picture of it. Not a big deal. You know, you can look through it. It's pretty standard stuff. There's nothing new there. Keep the weight close to your body, neutral spine, whatever else it's going to be. Okay, now the big thing where this whole story started for us was looking at how the desk-bound worker is spending their day. So we have a couple of pages that you can give to patients that show ergonomic setups of their desk. If you look at this, you want to be in a standing desk, sitting desk, you want to change your position. I'm going to go back to my starting point right here. If you come over here and look at my setup, what do we have? Well, look at this. It's a standing desk that goes up and down and it'll take you all the way through a variety of positions. There's a gym ball here. Sometimes I'll go onto my knees. Sometimes I'll even do this crazy thing like after 45 minutes say, I can't sit here anymore, and I'll get up and move around, all right? And that'll be one of the key ones right there, getting up to move around. All right, and if we're back out here, nice. Okay. And it talks about angles and setups and all of that. It's just, again, another way for you to establish yourself as an expert in what you're talking about. So let the patient see that you have this knowledge. Give them real things that are going to change how they actually set up their workstations. It makes a big difference given the amount of time you spend there. All right, next one is going to be exercise benefits. Get me on this. You are failing your patients unless you are giving exercise in rehab. It is across the board one of the best outcomes for preventing future injury. We have a good summary article here that talks about stretching. Stretching is good for a little bit of prevention. It's better for improving activities of daily living and quality of life. But if I want to prevent future injury, the real win is from strength training all the way through. And we're looking at 60, 70% reducing the risk of injury if you have good baseline strength to prevent it from happening. We talk about how many reps you should do and all that for patients, but that's a simple thing that you can do. The entire rest of the book, which is like another 30 pages, are progressions of exercises where you're going to pick which exercises you want to do for the patient depending on the specific level of their skill set and ability. And it's going to vary from person to person, how body aware they are, how fit they are. We start off nice and simple, pelvic tilts. I would just give somebody this page right here, and it says number of sets and reps. You can put your clinic stamp in the center of it and give it to them. They can take a picture of it, whatever works. All right? Then we increase levels of progression. Then we increase levels of progression. All of these are designed for people to do at home without gym memberships. You can do all of these easily yourself. And I'll give you my couple favorites here in just a second. Cat-cow, we're going to be those ones right there. Again, Vizniak, low back pain on YouTube. Just look up this video right here and you're going to see her talking about it and what we actually did. My favorite two exercises to give are an unloaded spine doing cat-cows. So let me just set this up here. An unloaded spine doing some cat-cows. It's a nice way for you to find a little bit of range. So what happens is the person's going to be on their knees here. They're just going to keep their back relatively straight. And if they can even just do this, that's a good starting point. Find where they have a little bit of pain, a little bit of discomfort, and then get them to work through a little bit more range if they can. Those movements, because gravity is pushing down on you, are a great way for you to start to move the spine under their own biomechanical control and start to develop body awareness in a safe method. And you're like, well, what about a significant disc herniation? When I herniated my own disc, day 3, and we're talking like 9 out of 10 pain, I was doing that. If you look here at this patient right here, she's going to go ahead and show you the same thing. She's on morphine, she can't breastfeed, and she's doing light movements like that. All right, that's your starting point. Okay, what else do we have to get out of this? A couple of other things that we need to get is, we just finished this book right here. 1,000 no gym workouts. We've got the ebook and there'll be a printed version of it as well. Again, 1,000 different ways that you can make this better. You might have noticed this as well. We've got this sex with low back pain. Patients will ask you about positions and ways that they can still continue to have sex without injuring their back. So we go through here and give some basic positions that you can use, and then we go into some more advanced ones that you can actually use for more rehab type focus right there. So if you're watching this, you can go get that poster. There's over 100 different poses you can use and positions you can try out for optimal back pain relief is what you're looking at here. If you want to get a little bit more out of this, we also have all of these posters that you can use, and literally it's $100 for 12 posters, and these posters have over 1,000 exercises, and all I literally do in my office is I have patients come in and I'll say, I want you to do this one and this one. I give them 2 or 3, they pull out their phone and they take a picture of it, and you're done. That's your rehab exercise, okay? Super simple for you to do, easy for the patient to get benefit from it, and it looks great on your wall. And again, you're establishing yourself as the expert. It reminds you to do rehab exercises. And we have everything from simple body weight and stretching and yoga all the way up to kettlebells, barbells, dumbbells, suspension gyms, elastic exercises. Whatever you can do to motivate a patient. Foam rollers. I'm loving foam rollers for mid-thoracic tightness. Foam rollers, all that stuff is available, and it's simple and effective. What does everybody want? They want to push the easy button. The easy button is literally pull out your phone, picture of this, done. Rather than sending an email or whatever else it is, nice, easy ways for you to get patients to do rehab. But they still need your expertise to make sure they're doing it right for them. You are the expert. You're there to help. All right. What else do we see as we finish this thing up right here? We are looking for success. And one of the key things you need to talk about for your own endeavors and for patients as well. What do people see is what's here on the top of the iceberg. They just see the success. You've done something amazing. You've accomplished your goals. They don't see all the hard work that went into it below the iceberg here. They don't see the rejection, the time, the tears, the self-doubt, the sacrifice. So that basically concludes this section right here. If you're on the Facebook Live version of it, you can go ahead and ask me some questions. If you are on the Instagram, I don't think I get the questions that way, or you can just direct message me as well. Where do you find real success? There is some real success. I would again refer you guys to our website, to our CE seminars, to Siva Wellness, to the Pro Health Clinics, whatever else it is. All of these things are available and there to help you if you want to get patients better faster. This is the way to do it. What I realized in practice of late, I'm giving people these entire full booklets right here. They don't want that. They want to know, what do I need to know to get better? Give me 3 easy steps so I can get rid of my low back pain. That is what these are about. And again, putting your own business card on the back is a nice way for you to say, I am the expert. I can help you out with this. So I want to thank you all very much for your time, and hopefully you found this very useful. I look forward to seeing you in future seminars, reviewing future books, and stay safe and have fun.